he would stand around in front and palpate like the medial end of the clavicle, and then have them hunch their shoulders up. See, and those joints should hinge. Now, if one side is dysfunctional, that side will ride up. And then how he did the shoulder, he would palpate over the AC joint. And again, when you abduct and you go above 90 degrees, that should hinge down. And the side that doesn't will just ride right up. Okay? So then that was 2 steps. I'm lazy. I like to do things in one. So what I realized I could do is if I stand behind the patient and get the tips of my first fingers right over the SC area, then I can use the lateral part of my hand over the AC areas. And then I'm using my thumbs as a fulcrum, and I'm not squeezing them like this. What I'm trying to do is glide like this. And let's see as we do that. If I glide the left side, I'm getting a pretty good glide, and as I do that, I'm feeling movement at the SC and the AC. Now, when I come back in the right side, man, this thing fights me. Can you feel the difference? Is that the shoulder that's been bothering you? Okay, isn't that neat? Have we ever talked about that? But see, what's neat is, like I was saying, well, I like to get a lot of the first time I see a patient, I would all sit down and do a history and then do a physical and all that stuff. After they come in every time, I like to just, as soon as they come and walk in the room, say, stand up, and why I screen them, then I get my history for that day. And I get so much more information out of doing that way. And a good example of how people can misinterpret what they see is people would once in a while say, hey, do you mind if I come in and spend some time with you in your office? I said, no, fine. And it was so funny because about halfway through the morning, they'd all say the same thing. And they'd say, I am amazed at your patients. And why? They said, the respect they have for you, because as soon as you walk in the room, they stand up. I said, yeah, because they know I'm going to screen them. Has nothing to do. So as I bring this right back, it's really fighting me at SC, but I've got better, can you feel it? I've got better movement at AC. Now, let's have you bring both arms forward. Okay, go as high as you can. Yep. Then go back. Bring them back, extend back, yeah. Okay, now abduct bilaterally. Okay, now reach behind your neck, then reach behind your back. Okay, so let's see. Now, look at, when I palpate that, isn't that right side higher? You can see. So, then what's the principle of muscle energy? We're using muscle to functionally change the origin insertion. So what muscle could we use to glide this thing down? Subclavius. See, and what was so fun when I was chair at the school is I'd say to the students, what do they tell you about subclavius? They say, oh, it's just a little muscle, nobody pays much attention to it, it's not very important. So I would jokingly say to them, that'll get you through the University of Kentucky and the University of Louisville Med School, but it won't get you through here because I'm going to be teaching how to use that muscle. So the way Mitchell taught these originally, he would have the patient laying down and extend and you had to work like mad. Then I found out, man, you don't have to work so hard. See, and if I can stabilize this shoulder with my elbow. See, and I've got my trunk, I can glide her forward back till I feel everything localized right there. Then if I just try to bring her arm back, I cannot get that to localize at that SC. But if I push up a little bit and then come back right there, I can start to feel everything localized at that SC joint. Now, what do you think I'm palpating? So I've got my finger and my thumb monitoring the medial end of the clavicle, and this finger here, I'm monitoring his subclavius kicking in when I have her make her muscle effort. See? So if you think about what information do I need to gather to know this technique is working? Is the bone moving and is the appropriate muscle kicking in? Now pull your elbow forward. And subclavius is kicking in like everything. And relax. See, and then fiddle and diddle and find, and when I side bend her a little bit and rotate her whole trunk, that localized to the SC joint even more. See, and that's why I don't like techniques because they'll say, you know, always bring the arm 45 degrees See, and then abducting and adducting, if I abduct a little bit right there, that localizes even more. Did you feel the difference? And if I internally rotate, it really, see, so then what am I doing? I've taken the technique principle, where's the, yeah, I've taken the technique principle, then fiddle and diddle and to modify it to this specific patient. See, and when you do that, then it's a whole different deal, because it's customized techniques for that particular patient. Now pull your elbow forward again. And stop. And it can be different at each level. Now this side, I want to abduct even a little more. Now it wants to externally rotate. Now pull your elbow forward. And stop. And her elbow popped. But now that's level. And when I glide this back now, there's good movement on the left side. There's still some restriction on the right, but I'm feeling movement here. Now I'm picking more up out at the AC joint. Okay. Now, what if that clavicle had been caught down, it wouldn't come up. What muscle would we use to correct that? Sternocleidomastoid, yeah. See, and you can do that with them sitting. See, and you can palpate it and say, now push your head forward a little bit, now turn to the left, turn to the right. That's kicking a little better right there. See, and I could have her could do that again sitting, whereas a lot of times people would have them lay down and do it. So again, learn the principles, then you can treat them in about any position. So now we've got an AC joint, and when I come in and palpate the spines of the scapula, and try to get to the medial board of the scapula. The right scapula is higher than the left. And that's the common pattern. And think about that. If that scapula comes up, what does that do to the coracoid process, bring it down? These are the people lots of times that get the entrapment syndromes. And lots of times it's directly related to that AC joint. So how are we going to treat that? So if I get her arm, I want to bring that scapula down. So if I externally rotate the arm, I can use the muscles of the shoulder girdle to help bring that scapula down. Then I'm going to palpate over that AC joint and get that as relaxed as possible right there. Now what I'm going to do is I'm going to put a caudad pressure on the distal end of the clavicle, because what are we trying to do? We're trying to hinge that joint. So then, and if you see, and if I do it like this, I'm going to be working hard. I'm putting a lot of stress in my own back. But see, if I tuck my shoulder in and get my elbow up against my trunk, then she's working against my trunk. I don't have to work hard. See, and you don't get paid more for working hard. So push your elbow down and stop. And again, now I've got the mechanical advantage. And stop. And the key is pushing down on that. Ooh, that was nice. Now push down again. Now, if the scapula had been caudad, the technique would be exactly the same, except I would internally rotate the arm to use the fascias of the arm to bring that scapula cephalad. But still what you're trying to do is get that hinge motion in that AC joint, because if you lose that, then that can inflame that bursa underneath there.
What muscles are you using? Like,
A lot of them. Yeah.
So it's not as direct as
Yeah.
the other
No,
one.
that one you're probably really kicking in a lot through the lats. Now, feel the difference. Now, move the shoulder around, or both of them, compare them, flexion, extension, internal, external, see if it feels any different to you. Because it didn't look like there was mark. Are you seeing a difference from up behind your neck? Yeah, that looks like it's better. So what changes are you seeing? How does it feel to you doing it now?
It's fine, I still felt like it's kind of catching right here.
Okay. So, see, so that, now we're treating you out of sequence, maybe. No, but see, here'd be a good one then. See, what I do is get a hold of that scapula. And it wants to go cephalad. Now, this is a functional technique, so I'm taking it medial. My right hand is, I'm grabbing the scapula.
Can we turn around?
No, that's okay, because then they won't be able to see through me. And then it wants to go clockwise. And as soon as I did that, then I'm putting compression in with the left hand right towards that hand on the scapula. And man, it'll start moving around and.
Is your left hand specifically from holding a phone?
No, I just got the whole anterior part of the shoulder girdle. Ah, that was nice. Right there, it stopped. Now, move around, see if that made a difference in that.
I just creak all over this.
Does it feel any different to you? No.
Right here? Yeah.
Did that change that there? Okay. Now, the other thing we're gonna do, let's do the whole arm. Let me have you turn facing this way. See, in a big, this radial head technique, this thing has gotten me out of more trouble professionally. Because one time, this was in the early 80s, and there was a medical journal, Patient Care, and they called me one time and they said, your name keeps coming up, we've been talking to people all over the place, and we don't know, we've had DOs on, because their expertise was, or their uniqueness was, it was a family practice journal, and when something new came out, they would identify people that were supposed to be experts in that, bring them in, they'd do a weekend seminar, get it out, and in 3 months they had it out. And so they would be like 2-3 years ahead of the New England Journal and stuff like that because they had a rapid turnaround. And it really played a neat role for practicing physicians. So they said, we've had DOs on the panel, but our editorial board and everything, they don't know anything about the osteopathy. And would you come in and do a weekend seminar for them in Connecticut to talk about osteopathic medicine and low back pain? And I said, well, if you want me to come in, I'm not gonna just talk about low back pain because you're a family practice journal. This applies to all sorts of other stuff, headaches and chest pain and GI symptomatology and asthma and stuff. So if you're gonna limit to me even low back pain, I'm not coming. But so they agreed they'd do this. So then they had all sorts of consultants come in and artists and photographers and stenographers and everything. And I walked in the room and I thought, what, you could literally cut the air. And I thought, holy mackerel, what have I gotten myself into? And so I thought, how do I do this? What are the barriers here? And so I said, you know, you're all MDs. There's a lot of misunderstanding about the osteopathic profession. And the reason is, in my opinion, is we've done a poor job of telling you what we really do, and it's not your fault, it's ours. They started quieting down. So then I said, let me show you something. Because what we're treating is somatic dysfunction. It's not out of place. We're not trying to put things back in place, put it in range of motion. So I said, I need a volunteer. So this guy volunteered and checked, and his right wrist, he could hardly pronate that thing at all. So I said, okay, everybody that wants to see this and feel it, I want you to come up. So everybody came up, they checked and said, oh yeah, we can see, you can't pronate it. And, oh yeah, that has a hard infield. The other side, there's spring. I said, okay, that's because the elastic barrier on this side, restrictive barrier on this side. And then I thought, great, man, I got him to appreciate this. And I thought, that thing doesn't feel like it's going to change, though. This may not be so good. So then I said, well, let me show you how, if I functionally change the origin insertion. So if I take that and pronate it up to the restrictive barrier, then have her try to supinate the wrist, and I resist it, then the muscles that normally would supinate the wrist will pronate the radial head. And the thing released like everything. And it turned out the guy that volunteered, he was one of the key king players in the Board of Trustees of Patient Care. And then he said, could I say something? And I said, sure. He said, this elbow's been bothering me for 3 months. It's been injected 3 times. This is the better it's felt in 3 months. The whole attitude of the meeting changed. So I found this is a neat way of, if you're dealing with MDs, to show them what mechanical dysfunction is, what the principle is you're treating it, see, and then it's not like you're doing something voodoo or you're popping things back in place or stuff like that. And it was amazing how the whole atmosphere in that room changed. And then remember when I was talking about the ribs through, 1 through 5 caught in inspiration and how that could produce chest pain and radiate to the shoulder. I said that, and a guy jumped up in the back of the room and pointed at me, and he said, "I'm an MD internist, and you just described a third of my patients what to do." And man, he was in there learning how to treat ribs and stuff. It was a hoot. So this thing doesn't want to pronate. So then I'm going to be palpating over the radial head because I want to get that up against the barrier. But see, normally they'd say have the elbow at 90 degrees and make sure you're on the distal forearm, not the hand, because if you are, then you're dealing with the wrist. So I'm going to pronate up against that barrier, but then look at, if I flex that elbow a little more, it relaxes even more. If I abduct the arm a little bit, it relaxes a little more. Right? And when I internally rotated it, it really relaxed. See? So there it is, taking the principle, then modifying it to the patient. And the next one you may find it's totally different movements. But see, then what I would say is you've got like a restrictive barrier and it's this big. And when you fiddle and diddle and fine tune that, you may get it down to where it's, and then what happens is only the prime movers kick in, synergists don't kick in, antagonists don't kick in, you get a nice clean response for muscle energy. But that takes muscle energy to a whole nother level. Now turn your wrist back towards me. And stop. And I find radial head dysfunctions are so common in people with carpal tunnel. Now turn your wrist back. And many times you get that going right, that helps the retinaculum at the other end takes a lot of the tension out automatically. Now again. And stop. We got to pop both ends, boy, don't tell anybody, it'll ruin my reputation. Yeah, see now we've got, they're symmetrical, and I can now, if it wouldn't supinate, then what would I do? I would have supinated, then fiddle and diddle, fine tune, and then had her try to pronate against my counter force. Okay. But a lot of people with these chronic elbow problems, man, you can really help them tremendously. And like I said, the other end of it can really affect that retinaculum, and I find that's a common bit. Nobody has looked at this up and into the shoulder with people with carpal tunnel. They're just focusing in this area. And again, what I tell people is, I don't know how much of your carpal tunnel is functional and how much is structural. But I've had patients that were in bilateral splints. They said they had to have surgery and got them out of that, and they were perfectly fine. I've had others treat them, didn't change it one bit. So what I always say to patients is, let me examine you. If there's a mechanical thing that's playing a role in your problem, and if I can change it, I may be able to help you. If I can't, it's not a waste of your time and money. At least we eliminated a simple possible explanation for your problem. And then, but then it'd be nice, wouldn't it be nice to get them working as well as possible before surgery? Because I think you get a better surgical outcome when you do that. You know, because think about it, if you're altering structure and it's mechanically altered, logic says you're probably not, you may not get the best outcome you should. Okay, so see what we're doing with SCAC. Now move the arm around, see if that changed that catching spot around the scapula. Did it? Very good. Okay? Oh, you were just stretching out, not raising your hand.
I was feeling my own body.
You want to do the wrist?
Huh?
You want to do the wrist?
Yeah, let's, how I usually treat the wrist functionally, because the carpal bones, I laugh at the carpal, I had a tough time in medical school because I am not a good memorizer. I've got to figure things out and understand them and not memorize. So they keep changing the names of the carpal bones and they change the mnemonics and everything. But so when I give a lecture, I got to look it up again, and I didn't do it this time. So just remember, you got 2 bands of carpal bones. And just flex and extend along those 2 rows of carpal bones. And many times you'll find one area, boy, that's a little restricted right there. So then just get your thumb on one surface and a finger on the other surface. Then like you're shaking hands with that patient. then take it to its balance point. And then grab the forearm with your left, in this case, your left hand. Your right hand, you've got like the handshake. And then just put compression into that area where that bone is. And man, you can change carpal bones in wrists. I've seen people that have had a lot of occupational therapy and they just did not respond. You do this and get an unbelievable response. But it's a neat technique. It's a functional technique, and you're just unwinding those. That mobilizing. Now that's moving good. But just to work through, and sometimes you're gonna have to do 2 or 3 different carpal bones, but they can, you can make a big change in them. And a lot of times people say, boy, that's made a big difference in that wrist and how it feels. And you'll find the carpal bone dysfunctions, again, with the people with the carpal tunnel syndrome. Sometimes you get those working right, it's a functional and it's reversible. And you get them going and they do well. And if they don't, then lots of times be sure, or if you can, see them after surgery. Because then lots of times, once they've had the surgery, then you can get the movement back because you've taken out all the adaptation and stuff that was secondary to the pre-surgical condition. But see an awful lot of people who've had carpal tunnel surgery and didn't get a good outcome, and then treat out what you find, and particularly with those carpal bones, and have them say, hey, that's the best that's felt since I had the surgery. So get a partner, go to check.